Good evening, doctors. Welcome to First Aid AMC. My name is Mavish, and we'll be doing a random recall session tonight. Hope everyone is fine and doing well. Please confirm you guys can hear me or see my screen clearly. Okay, thank you, doctors. Thank you. Appreciate that. Okay. I would like just to give another 2 minutes so all other fellows can join and we can just start the session for this evening. Okay? Okay, doctors, let's start the session. So we have a first question. Okay, so this is a 10-year-old female with 3-day history of fever, painful sore throat, and large left side tonsil, displaced to the right side, muffled voice, pooling of the saliva, first line treatment for her, please. So urgent referral to ED for ENT review or phenoxymethylpenicillin 250 mg BD for 10 days. We just have two options. So what do you think would suitable for that child in that case? Good. Yeah. So it's peritonsillar abscess, which is also called quinsy, and it is a complication of tonsillitis. So we can have a look on this one. So the answer would be, see, if the patient is coming to you with the just inflammation of the tonsils, you can start with the phenoxymethylpenicillin. You can give it to them after checking their penicillin allergy. But this patient has quinsy. So she has developed peritonsillar abscess, which is a surgical emergency. You have to immediately refer that patient to ED and they will take it from there. So I can show you this guideline from RCH. It's for sore throat or viral pharyngitis. And when the complication happens, we just wanted to look on the complications. So this is group A streptococcus pharyngitis. They can cause non-suppurative complications, which can include rheumatic fever or glomerulonephritis, and suppurative, which of the common of this peritonsillar abscess or called as quinsy or retropharyngeal abscess is another of the complication. Now, how do you assess that child? Obviously, first of all, with that kind of information and with that acutely sick child, you have to make sure that the airway is not obstructed. So we start our approach as ABCDE as a normal approach. And when they obviously did the approach, they had seen that the uvula is deviated, the patient is drooling, which is a complication of epiglottitis when it's happened, or pharyngitis. So in that case, the airway is obstructed. Now, first of all, you have to remove the obstruction of the airway, but that child, or that child is so sick that you cannot do anything. You just had to refer for the surgery or refer for the ED for ENT referral. So when sometimes the children come to you, in that case, or what you can assess, you have to assess their hydration status, check if they still have the fever, check for any ulcerations, exudates for tonsils, hypertrophy, asymmetry, deviation of the uvula, tender lymphadenopathy, cervical lymph nodes. Then you can check for hepatosplenomegaly. So this is on bottom, but if you can stop here and you would just know that this case is a surgical case, you would just treat, refer for the ENT surgery. And these are again the red flags. So toxic appearance of the child, respiratory distress, stridor, drooling, trismus, or muffled voice. All of them were included in our question. And this is the management. So this flow chart is quite helpful when you see the management in the upper airway obstruction, when the child is severely unwell, how you can refer the child and what you want to do. And then if you can come here, this is the question, peritonsillar abscess, Quincy. All the information is here, which is concluding in a question. Refer to END for the consideration of the drainage. You can start benzyl penicillin, but as the child is severely acute, you cannot start in your surgery. It will be started later on. If you're in hospital, you will start there. Then you can switch to oral therapy, the oral therapy here. Okay, clear everyone? This is a complication, Dr. Fezia. So when the uvula is deviated, that means the abscess is there. So it's deviated to the contralateral side, the side where the abscess deviated to the opposite side. That means the abscess is there on the side where the infection is. Okay, all good. Moving on to the next question. So this is a 45-year-old female with pain swelling over radial styloid, aggravated by writing, grasping, and positive Finkelstein's test, likely diagnosis, DQ variant tenosynovitis, carpal tunnel syndrome, or trigger thumb syndrome. See, these type of questions sometimes comes up to boost up your confidence when something, a typical test comes up and you know that that test is for some investigation, is for something which we know. And in that case, it's DQ variant tenosynovitis, which we all know, we all hear about it. So I don't know how long the question was, but definitely if this test is coming up, you know that it's DQ variant tenosynovitis. And those who don't know what is DQ variant tenosynovitis, we just wanted to briefly have some information. So it is a test, a proactive test with the diagnosis. Now it was hypothesized by some scientist whose name was Finkelstein. And what happens, two muscles, extensor pollicis brevis, EPB, and abductor pollicis longus, so thumb muscles basically, the thumb muscles are in the extensor compartment, are responsible for this test. So I don't have the picture. I think I should have put the picture here. I don't know, many of you have seen them, the test. So what we do is we ask the patient to just put their thumb towards their wrist and then on the palmar side, and then we ask the patient to overlap their fingers over their thumb and ask them to move the wrist towards the ulnar side. So when the ulnar side, the patient is moving their wrist towards the ulnar side, these extensor tendons are stretching and they brings about the pain. So this is the Finkelstein's positive test for especially these two muscles. Okay, everybody get it? Okay, so this is DQ variant, and yeah, we have, I think, one reference here. So maybe we can just see if they have shown the test for this one yet. There is no picture for, yeah, see, have a look here. So ask the patient, move the thumb towards their palm, and then we ask the patient to close their fist. So thumb down, fingers below, and we move the wrist towards the ulnar side and stretch the extensor pollicis longus and abductor pollicis brevis tendons. And then in that case, the pain is introduced. So this is a test positive. And then again, the treatment depend on the severity of the condition. We can always start the conservative management with NSAIDs or NSAIDs injection, or we can provide them with the splint and refer for the physiotherapy. This is splinting, injection. This is a good reference actually, so you can read it in your time. Okay, next question is, this is 67-year-old female with tinnitus and left ear hearing loss for 2 weeks. No pain, vertigo, normal examination. Sorry, my bad, I showed you before. Now, Weber test lateralizes to the right side. What type of hearing loss is it? Don't worry, you can have your time. Think about it. What type of the hearing loss you think it is? Either it is left-sided sensorineural hearing loss, or it is left-sided conductive hearing loss. So do your, do your exam and just see the Weber's test lateralizes to which side, and then type your answers. Great. So we all understand it's A, left-sided sensorineural hearing loss. This is the answer. Do you want to discuss this question, or are you guys happy to go ahead? Okay, so we can just briefly discuss it for those who don't understand. I know it's a bit confusing, so we can just quickly discuss it. I think I have a screenshot of this test, so makes easier for us to understand. See, we have two hearing loss tests. First is Rennie's and second is Weber's. So what we do is we take the tuning fork and we put the patient. So first of all, we want to check the ear conduction and bone conduction. So you hit the tuning fork and you place the tuning fork inside over the patient's mastoid. And so I'm talking about Rennie's at the moment, right? And then what you do is you ask the patient that on the mastoid, let you know when they cannot hear the tuning fork anymore. So your patient will tell you, yes, I cannot hear it anymore. Then you bring the tuning fork close to their ear and see that it can still hear it. Usually ear conduction is more than bone conduction, and it is always there. So when you have a normal hearing, ear conduction is always better than the bone conduction. And this is called Rennie's, okay? Now we come towards the Weber's, so which is a test here. Now, in the Weber's test, what you do is you strike the tuning fork, would you put the tuning fork in the midline or the head or the forehead, and usually the Weber's lateralizes to the diseased ear. So if there's a disease in one ear, so if you go back to question, this patient has a hearing loss in left ear, okay? But Renes lateralizes to the right ear. So if Renes was positive, Renes has to lateralize into the normal ear, but this lateralizes to the diseased ear. So this is why the patient has a problem in the left ear, not the right ear. And it's the sensorineural hearing loss, not the conductive hearing loss. So you conclude the sensorineural and conductive with the Renes, and then you check what ear it is, like it is left side or right side with the Weber's test. So this Weber's was lateralized to the right ear. That means right side was good and left side was diseased. This is why we conclude it's a sensorineural hearing loss on the left side. And I think I have the Geeky Medics video as well. So maybe we can have a look on this video as well. I don't know how does it plays, but we can just quickly see in this test. Okay, let's do the Weber's, okay? Because if we do the Renes, it will be confusing. Let's do the Weber's. I don't know, it's not moving on. It's just not moving on. So maybe it's not a video. You can have a look here. So you put the tuning fork in the middle of the forehead. And then when your ear is normal, the sound is equally heard in both ears. When there's a sensorineural hearing loss, the sound is heard louder on the side which is right, like which is the intact side. And which when is the conductive hearing loss, the sound is louder on the side which is affected. So in our patient, we had the sound. I can go back. We have a sound, the Weber lateralizes to the right ear. That means a left ear was affected with a sensorineural hearing loss. Okay, guys, clear everyone? Clear? Good. Dr. Suparna, we just did one question. You should have the question in the portal, please, because if I go back to the question, we will just waste more time. So it's not a very complicated question. You should be able to get it. Okay. Thank you. Okay, this is another question. So RTA patient, BP is 80/50, GCS 10, saturation of oxygen was 90, breathless, other vitals were normal. Other vitals, they means the heart rate or maybe the temperature or respiratory rate. What is the immediate next management here? Intubation, oxygen, O negative blood, or 1 liter of normal saline? Okay, so for these type of questions, what you want to check is you want to check the vitals first of all, and you wanted to do the ABCD approach, which we all know about it, but I'll briefly explain it. And I have, I think, a screenshot of ABCD, so we'll quickly go through it. Your patient is losing the blood. GCS is 10, so it's not good. You know, anything less than 12, we have to just check it, because if it's less than 10, patient, you might be able to not do any more oxygen, because if you cannot secure the airway, you might not be able to give them the oxygen. Though they are breathless and the oxygen saturation is 90, but first of all, the most concerning thing for me here is GCS. They are dropping the GCS. GCS is just 10. If you are thinking that you will give them the oxygen, you cannot give them the oxygen because their airway is not intact. So there is no point of giving them the oxygen. So first of all, what you want to do, you want to intubate them. With the intubation, you will secure their airway. Now you can provide them with the oxygen. Either you can provide them with the mask, you can give them the mask, or because the nasal prong's not going to work here. So with the intubation, you can provide that with the mask, and then you can do the other things like providing them with the blood and things like that. But start with the intubation because the patient is dropping the GCS. So you don't know how much GCS they are landing on. Still at 10, they won't be able to maintain their airway. Yes, because your patient is also losing the blood here, Dr. Fezia, and GCS is 10, so you will not be able to secure the airway if you will not intubate it. Yes, you will. So if you're providing them the oxygen still, since they are hypotensive and breathless, they will not be able to hold it. Okay, so I can show you here. If the patient was normotensive or they were not losing that amount of blood, you should have thought about giving them the oxygen and bring up their blood pressure. But since they have lost so much blood and they're already breathless and their GCS is dropping, so if you want to give them the oxygen, it's not going to work. If you want to give them the blood, not going to work because they will generally will not be able to maintain their airway. So with ABCDE approach, what you want to check is you want to check their airway. We all know. You want to check the patency of the airway. So an intervention, what you can do about it, you can secure the airway, obviously with intubation, open the airway and give them the oxygen. Then in the B, which is the breathing, you want to check if the patient is breathing well. In that way, you can check their ventilation and oxygen. In breathing, you can check again their oxygen. Circulation. In circulation, you have to check their blood pressure, heart rate, and capillary refill type. Sorry, that slide again. And then you have to stabilize their circulation and obviously insert the cannula and provide them with the fluids or they need the transfusion. Then this is D and E. We're not going into the details. So this is disability and exposure. So usually with the accidents and emergency, approach starts from ABC and you go from there to D and E. Yes, you do intubation in less than 8 or 8, but as I'm saying, your patient is losing the blood. So they might not be able to maintain their airway if you are giving them the oxygen. That's right. That's right. Patient is impending collapse. This is the right term because your patient has lost the blood. That's what I'm saying. If the patient has the normotensive or the blood pressure was not that much low, then you can think about giving them the oxygen. And with the oxygen, their saturation would be fine and their GCS can improve. Yes, Dr. Rehan, this is right. So first we have to approach the airway, and approaching the airway is both ways. You have to give them the oxygen, but the thing is they would not be able to maintain the airway if you are just giving them the oxygen without securing their airway. Have you checked, Dr. Hira, that what was the question you're talking about, was the patient going in a shock? So this patient is going in a shock. So if your patient is going in a shock, you have to secure the airway first. Okay. If the patient is not going in a shock, then you can provide the other things in maintaining the airway and circulation. Is this clear for everyone, guys? Or any more questions with that? Any more confusion? Okay, we have, I think, this algorithm as well. Let's have a look on this one. This is again the ABCDE survey. I think we spoke about this already. So this is already there. There's not much information we will discuss. So I think this is fine. You can just move on to the next question. No confusions? Okay, good. All right. Next question is this is 36-year-old female, obese, heavy drinker, and smoker. BMI is 32, carcinoma breast, asking for the contraception, which should be considered prior to the prescription. Alcohol history, smoking history, obesity history, or carcinoma breast. Okay, Dr. Espa, I'll see this chart in a while. Just finish this question and we'll go back, okay? All right, so this is obviously carcinoma breast. So if this patient is coming you for the contraceptive advice, above all, you will have to check for the carcinoma breast and then you can advise the contraception accordingly. Let's have a look on this reference. Just maximize it a bit. Usually for the breast cancer patients, we opt for the non-hormonal therapy, which can be the IUDs in terms of the copper or the barrier methods you prescribe there. I don't think so. There is much information here. This is, I think, the normal COCs. But usually it's the non-hormonal, or if they want to have some IUD, then it's copper IUD. Or we can just ask them for your barrier methods. With the active carcinoma even, or the carcinoma history even we want to take into account. Going back, what Dr. Asfa has shared, just have a look. Maximize. Okay, so this is here, airway management, assess the breathing effectiveness. Breathing is effective, ineffective. So patient comes here. If the GCS is more than 8, so this is the patient standing here. Breathing is ineffective or absent. What you want to do is maintain the C-spine, open the airway, or consider the inserting oropharyngeal or naropharyngeal, and you have to administer the oxygen. So you have to administer the oxygen because you have to secure the airway and you have to insert them with the oxygen. Yes, is the airway and ETT. Yeah, so this is the endotracheal intubation here, Dr. Asfa. See, so a patient is breathless, and when you give them the oxygen, it's ineffective unless you have to secure, you would have secured the airway. So I think this chart is giving the same information as we have previously discussed. Do you have any more questions about it? Okay, thank you so much for sharing that. And I think we are just concluded with this. If the patient, I'm glad you just shared it. So those who have a confusion about the GCS, so agreed, if the patient is less than 8, then go for the securing airways no matter what. But if the GCS is more than 8, you have to secure the airway if they are breathless and if they are in shock. Okay. Next question is this traveler is going to climbing having high altitude syndrome. So I don't know what the exactly mean is. So he is going to climbing. That means that he is going to have climbing and already have high altitude syndrome. What to do? Give them DEXA or ask them for the DEXA scan. I don't know. This was thing. This is why I just put it DEXA, prednisolone, acetazolamide. Advise not to go. Yes, this is acetazolamide. I think we have done similar sort of question. I don't know if this is the same question or a different question, but I think we have done yeah, we have, I think I have done this question, maybe not sure with this group or another group, but sometimes the recaller has just one line. So maybe it's the same question which is just roaming around. A traveler sickness. And I think I use the same reference. Is this the same reference? Yeah, this is the same reference I think we have done. Not sure with your group or the previous group. But this is the forms of the altitude sickness. So acute sickness and converting to the cerebral edema and the pulmonary edema. This group, Dr. Penn. Okay. Yeah, that's right. I remember that. Okay. But that question I remember was a bit big question, so easier to understand. And this question is just one liner, so I'm not sure, but that's fine. If we have done this question before and if other doctor has done it, so that's fine. We'll just leave that. Don't worry about it. You have already done the question before previously. Yeah, that's fine. Thank you, doctor, for sharing that. And I think we have used the previous reference as well, so we don't have to discuss about it. Are you all agreeing or somebody wants to discuss it? Skip? Okay, good. That's fine. Happy to move on. Okay. So this is a 40 weeks pregnant lady, primigravida, with vaginal bleeding after the intercourse. The BP is 80 by 56. Uterus is tender, hard. What is the initial management for that lady? Uh, Ultrasound, speculum examination, induction, IV fluids, blood transfusion. So they're asking about the initial management for that lady. Okay, is somebody able to give me the diagnosis here, please? That's right. It's placental abruption. And how would you know it's placental abruption? First of all, your patient is coming with the history of trauma, no matter what, but trauma. And then when you examine your patient, the uterus is tender and hard. And she has lost the blood because when you check the ops, now she is sitting at 80 by 56. In that patient who has lost the, and why the uterus is tender and hard, because the bleeding is happening, maybe the vaginal bleeding is happening, and there would be a lot of bleeding inside as well. This is why the uterus is tender and hard and might be separated. So we are not sure about the exact situation, but she is sitting at 80 by 56. Your patient is in shock. Okay. In that case, in that position, do we have the role of IV fluids better than giving her the blood? Because we want to save her life. At the moment, it's really hard to see if the baby is there surviving or not. So no point of doing the ultrasound speculum examination in ED, especially if I'm talking about the patient is coming in a shock with a tender heart uterus. You don't want to see how the baby is doing at the moment because you have examined already. Your patient is going in a shock. The main important part is to save the life of the mother at the moment. So in that case, you have to transfuse her because she has lost a lot of blood and she is already in a shock. And you might lose her if you don't want to save her life. IV fluids, giving them the IV fluids will just not maintain already the blood she has lost. So in that case, the O negative bloods comes up play. So if you know about their blood group, you can arrange the blood group. But if not, we have in O negative blood all over there. So we can start then the quick transfusion. And then, no, before even doing the transfusion, before giving the fluids, you can have the transfusion. So once the transfusion is started and she is stabilized, then fluids come play. But first of all, you have to transfuse her because she is in shock. No, not in ED. Blood arrangement, not in ED. We have O negative bloods in ED all the time. So even it takes time. I know cross matching. Usually we have, if the patient is known to the hospital or her history is known, her blood screening is there. But even if you don't know about the blood screening, O negative blood, you can quickly transfuse the blood to the patient. No, they see CTG and blood transfusion. CTG is different thing, and blood transfusion is different thing. At the moment, when you just examine your patient, and when she's coming the profuse vaginal bleeding, which brings about 80 by 50 blood pressure, uh, CTG doesn't matter. You can still do the CTG, but there is no point. You know that you cannot save the life of the fetus here. The important is that save the life of the mother at the moment. It's not fetus anymore. She's 40 weeks pregnant, so it's a complete baby. But since the uterus is tender hard, it is not very much important about the baby at the moment. It's about the mother because she is 80 by 50. So you have to save her life. And side by side, you can do the CTG no matter what. But you can just not stop the blood transfusion because you wanted to do the CTG, if you know what I'm saying. So these are the side by side things. You can give them the fluids, you can do the CTG side by side, but usually that dealing with that type of patient require multiple teams. So there is not one doctor who is just looking after that patient. There are the multiple doctors. So one doctor is there who might do the CTG. One is there who might start the bloods. One is there who can just send the investigation, things like that. So it's a multiple team approach. Okay, clear everyone, guys? And I think we have this trauma reference again for antepartum hemorrhage. So you can have a look here. So use O negative blood in this life-threatening hemorrhage and consider the early use of the coagulation blood if operative birth is indicated. So we are not sure about the birthing at the moment because they told you about the antepartum hemorrhage. They are not telling us about the placenta abruptio here. So if birthing is indicated, you can obviously start the coagulation products. But if there's a placenta abruptio placenta and uterus is heart tendered, so this is very hard to save the baby at the moment. So you have to at least save the mother. And if you can just see here, I'm highlighting here Dr. Rehan. So life-threatening hemorrhage, consider the early use of the coagulation if the baby is viable, but you have to save the mother. You can start them with the O negative blood. And I think they may have something for the abruptio. I think I've read it somewhere. I'm not sure where was it, but this is fine. If you can just read it here for life-threatening emergencies, there is the important rule of the blood transfusion. No matter what, you have to save the mom. This is not needed. Okay. As I said, if you don't have the transfusion option in the hospital, see, there are a couple of hospitals. There could be the rural hospitals, the hospitals which do not have the blood banks. So if you're talking about the other parts of the world and different countries, it should be a different scenario when they don't have the blood or you don't have the rapid O negative blood. Here we have our O negative blood in the wards. In the emergency, it just have to be filled and signed, and they can start immediately. So transfusion is always better if the case the patient is going in a shock. If the blood is not available, then obviously you can give them the resuscitation fluid. I'm not denying that. But if the option of transfusion is there, you will transfuse them first, especially if the blood pressure is going at 80 by 50 at some rate. So she is losing the blood. She is having the vaginal blood loss. She's already having the blood inside her uterus. This is why you are feeling the uterus is tender hard. So in that case, yes, resuscitation fluids have a role while arranging the transfusion. But if you have the O negative blood, why wait for the crystallines and fusions of the resuscitation? Um, See, Dr. Zainab, as I said, here there is no one man approach for one patient. Okay, so this type of patient, there's a multiple clinicians and the team is involved. Which guidelines are we talking about, Dr. Bushra? Are we talking about the Australian guidelines when the patient is in shock? The one we just discussed? Okay, let me have a look on again. Okay, let me go back. How do I go back? Wait. This is we talking about? Okay, so if you're talking about here, have a look here. See, so actions, assessment, and stop the bleeding. So if you want to have a look on the assessment, you have to check the uterine tone, vaginal loss, and you don't have to perform the examination. Vaginal examination is not done here. So if you come here and see, monitor the blood loss and also need for the blood products and ensure that the accurate fluid is there. So if required, what you want to do is if you want to go here and here. So monitoring is there and you have to consider the blood products if required. So consider O negative in emergency or FFP or fibrinogen or platelets, whatever. But the role of the blood is always there when there's a blood loss. Uh, Sorry, where is that? Under action. Action here. This one you're talking about? Okay, don't confuse with this one. See, the patient has a history of the bleeding here. If you want to come here in the assessment, yes, I get it. What are you saying? So you're talking about this one. I can't highlight this one. See this one, I think. If you are not, I don't know if you can see this one. Okay. So you are thinking about this one, rapid fluid replacement. Right. See here, when you have the patient who is losing the blood and you have assessed your patient with heart rate, blood pressure, and saturation, and you have a history of the bleeding here. When you have a history of abruption, previa, or rupture, or the vasa previa, and you have done the abdominal examination. So I'm just going down the flow. Okay. I'm not able to highlight it, sorry, but I'm just going with the flow here. So abdomen, you have examined the abdomen for tone, tenderness, and then you have to examine the vagina. This is all everything we have done, right? Now you are going there. So you have done the examination, your uterus was tender or tense, whatever. Then you have to assess your patients with the fluid or assess the well-being of the baby. So as I said, you can assess the well-being of the baby side by side, but for that you cannot stop the mother for their fluids or for their bloods. So your mother was losing the blood, and then you have to monitor the blood loss and assess the need for the blood loss. I'm just here, okay? Just there. So in that way, if your patient was required the blood loss, in that patient, the patient did not require has not the blood loss. See here. But this patient has the placenta abruptio and she has the blood loss because you examine the uterus, you examine the vagina, she has the blood loss. Now you have to consider the replacement of the blood if required. This is here I'm saying. What I'm saying is written here. I'm not sure if you guys are getting or not. But see, antepartum hemorrhage doesn't mean that you are losing the mother. That means that you can save the mother still and you can save the baby. So in that case, yes, you can administer them the IV fluid. But placenta abruptio, especially if the examination says that the placenta is tense or the abdomen is tense, then that means that there is very least chance that you can save the baby and the mother is losing the blood. So you have to administer the blood. Other cases, yes, you can provide them the fluid if she was hemodynamically fine. The role of the fluid in patient's condition is where your patient is hemodynamically not that bad. Okay, if you're getting my point. This patient is having a shock. So why do you want to put the fluids when you have the bloods there? I hope I'm clear, but you can ask more questions if you want. In this chart, they have given ultrasound and CTG. See, ultrasound and CTG, I'm not saying that you won't do, Dr. Merin. You would do, but you will not leave the ultrasound and CTG and you will say that, yes, we wanted to do ultrasound, you wanted to do CTG, and we wanted to see how the baby is going. Then we will transfuse the blood. No, it's not like that. So they will go side by side, okay? You have to assess the baby and you have to manage the mother as well. Okay, guys, I think enough of that question. If you still have some confusion, if we have the time, maybe afterwards we can discuss that. But let's move on to this next question. A 2-year-old boy, cough, irritating, not eating properly, wheeze, grunting, intercostal retractions, saturation of oxygen is normal. Which test will help to reach the diagnosis? Chest X-ray, CBC, blood culture, ABGs, or spirometry? Okay, and those who giving the answer A or D, do you have some diagnosis in your mind? What is the diagnosis here, or what should be the diagnosis here? Bronchiolitis, right. So this looks like it is bronchiolitis. Why? Because we don't have the fever. We just have the cough. We have the patient, the baby who is not irritating, though you have wheezing or grunting or intercostal retraction, but their oxygenation level is fine. So most likely it's bronchiolitis. Now, if we think about bronchiolitis, there is no test usually we do in bronchiolitis. So this question was actually quite confusing for me. So I'm not sure the whole story about this question, but whatever the information I have, seems like this question is bronchiolitis. But for bronchiolitis, do we require any investigation? No, we don't require any investigation. Bronchiolitis is a clinical diagnosis or clinical exclusion. We can just do that. So whatever clinical information we have, we already knew the patient and we already knew the diagnosis here. But why they want to separate to reach the diagnosis, I'm not sure which test. So I was thinking maybe they are thinking about any other pulmonary condition in the children, which they want to separate it, or they exclude the differentials. Yes, that's right. So apart from everything here, I think only chest X-ray is a thing which we still can do it. But why we want to do the chest X-ray? Usually for pneumonia. But pneumonia in the children still not required. Community acquired pneumonia in the children doesn't require the chest X-ray until and unless it is not severe. So in mild to moderate pneumonia, we even don't require the chest X-ray. But maybe there could be some other features in this question which the recaller has not mentioned. So we can just say maybe the chest X-ray, but I'm not sure about this question, the context of this question, to be honest. But everything else doesn't meet the question criteria. So CBC, no, you want to do the CBC, and CBC will not give you any information about the respiratory condition here unless it is infection. Blood culture, not at all, because we don't have the fever or anything in the history. ABGs in the child is not probably not needed at the moment because child is not sick at the moment or not as sick, which require the ABG, and spirometry has no role for the children here. So in everything else here, chest X-ray was a bit better option. So if this question comes to you, I don't know if the full question comes to you and what do you get from the whole question, but all of the options here, no, it's not required, Dr. Waleed. Bronchiolitis, according to RCH, we don't require any investigation. I can show you the reference in a while. But from all other answers here, chest X-ray was bit reasonable because at least it can give you some differentials about pneumonia. So you can just do chest X-ray if the bronchiolitis is so severe, and especially if the child is coming with the fever. Usually, when the child is coming with bronchiolitis, they have very low grade fever, or already the fever has subsided. Only the cough remains. Chest X-ray, and I can just quickly show you this reference here. So this is from the not Australian guideline, but I think I have reference from the RCH as well. After this one, we will do the RCH reference again. So there is no investigation required for the management and diagnosis of the bronchiolitis here. And we should not do any laboratory or radiologic studies. Now, if we do the bronchiolitis X-ray, it's always non-specific. Yes, you can see sometimes the infiltrates, but they are inappropriate. They cannot give you any information about anything else. So it's better not to leave it and better not to just give the information about the radiation to the children. Now, when you should consider the X-ray, when your diagnosis is not clear, when you have a suspicious of pneumonia due to the focal lung findings, when your treatment is not working, and when you have a severe respiratory distress. So in that case, yes, you can do the chest X-ray. So I'm not sure what was the full question. This is why I said that maybe you can do chest X-ray from all other options. It looks a bit better. And the treatment is supportive. You can provide them with the nebulization or give them the oxygen if they are low of the oxygen. So the patient we discussed was actually fine, so doesn't need the oxygen. Yes, you can give the nasal suctioning if they have some congestion. And I think that's it. I don't have the RCH reference, but if you guys want to do the RCH reference, we can just quickly search for that. Okay, just see this reference from RCF. The investigations are not indicated. The goal of management is to maintain the hydration of the oxygen. And you can provide them with the oxygen if they are having a low saturation, but the patient we discussed was fine, so we don't require the oxygen. And the assessment is just there. So this is all the patient can come with. They can come with the fever, as I said, and that can conclude the criteria of even doing the blood culture sometime or the chest x-ray. But this question didn't show anything about the fever. And this is the management here. So chest x-rays are generally not indicated and may lead to the unnecessary treatment with the antibiotics because they cannot discriminate between the viral and the bacterial infections. Blood tests are not indicated. They all include the blood tests like the cultures, full blood counts, blood gases, etc. Virology is not indicated. So symptomatic treatment with the oxygenation and hydration is all required. Okay. What are the questions? Yes, diagnosis is clinical, Dr. Rehan, but severe cases we have to do the chest X-ray. Yes, we have discussed if fever exists in the stem, Dr. Shabir. That's what I'm saying. So pneumonia is likely, yes. And then you can do, then you have the role. If the fever is there, then you can do the bloods. Like you can do the cultures, you can do the full bloods, you can do the chest X-ray because now you have the diagnosis, you have the differentials. So one of them is pneumonia. But if fever is not there and the patient is generally fine with their oxygen saturation levels, so we could not bother the child with those type of investigations. Yes. So if fever is there, generally with the fever and the children younger than 2. So let me check the age of this child. 2 years old. Yeah, you can do the blood culture first, and afterwards you can send them for the X-ray. Usually in the ED they have the urgent X-rays like on the spot, but the cultures obviously take time. So the diagnosis is generally made on the X-ray when you have the pneumonia, because cultures usually take 2 to 3 days. So full blood counts and the X-rays come on the spot, and you can do it. But cultures take time, so you can start the empirical therapy if the diagnosis is pneumonia. Okay, guys, clear everyone? Bacteremia can be due to many other causes. That's right. This is why we are taking the bloods, doctor. So if the child is coming sick, for the sick child, different approach. Okay, so this will be the approach for the sepsis. For the sepsis, you will send the bloods, you will send the chest X-rays, you will ask them for the urine, everything you will do for a sick child as a sepsis child. So if this child was a septic child, we would send all the investigations. But if the patient doesn't have the fever and they are clinically fine, there is no point of sending any more investigations. You can diagnose in the ED. So this, if the child is coming to you in your ED, you can diagnose clinically and on the chest X-ray because cultures take time. Okay, for the sick child, you can definitely diagnose with the chest X-ray and send the blood cultures. At least you can start them on the antibiotics, and when the cultures come up, you can check the resistance or sensitivity and start them later on. If the SPO is very low, then you can oxygenate them, start with the oxygenation, and then you can follow the same protocol. If it's a fever, then you can do the septic approach. If it's non-fever, you maintain the hydration, you maintain the oxygenation. Oxygen, doctor, oxygen levels. If oxygen levels are low, you have to nebulize them, you have to give them the bronchodilators, provide them with the oxygen. Low oxygen, without fever, no cultures or no bloods required. Fever is the only thing that can bring about other differentials like pneumonia, which is a main thing we have to consider in that age child. No other investigations are necessary. ABGs have a role, Dr. Suparna, when your child is acutely sick, when you have concern about their low oxygenation and high carbon dioxide retention levels, then you can do the ABGs. For a very sick patient who has a concern about their arterial bloods and arterial oxygen and carbon dioxide levels. But this patient, which is fine in terms of their oxygenation, you don't need the ABGs. I think we can get a break for like 10 minutes and come back. It's already 9:33. So take a break and come back in 10 minutes, guys. Okay. Okay, hello, doctors. Back from the break. Okay, let me share my screen with you guys again. Yeah, we went there. Okay, let's move on to the rest of the session. We did that reference. Okay. Next question is, this is a 7-day-old female baby. Birth weight is 2.2 kg, delivered at 36 weeks, brought in by mother to the GP for routine checkup and asking the time for starting the vaccination. When would you like to do the vaccination for that child? According to the chronological age, as per standard, when the weight gain, or when the mother wishes. Yes. So this is as per standard. Why? I think somebody was asking about A and B, Dr. Asfa. So chronological age is the age where the vaccination has been advised. So this baby was delivered at 36 weeks. So if she is brought in by the mother now, so for example, after 6 weeks, so that baby would be about 38 weeks or 37.5 something, or even 39 weeks. So this is the chronological age of that baby. So they are asking about that if that baby has to be vaccinated or that has to not be vaccinated because they are not up to the age of getting the vaccination, which is when the baby is born and then they get the vaccination, usually after 6 weeks' time. So this is they are thinking about, they have options about the chronological age. This is what they meant. As per standard, we know when the weight gain, there is not a criteria for weight gain, especially until and unless there is extremely premature baby, which is a different thing. But that baby was 36 and weight was 2.2, which is reasonable. When the mother wishes, no. So the answer for this is as per standard. This is from immunization handbook. And I think this is all the options are there, what we have just discussed. Uh, So preterm or premature infants are born between 37, less than 37, extremely premature or less than 28. So despite their immunological immaturity, preterm infants generally respond well to the immunization products, provided they are stable and no contraindications to vaccination. Preterm infants should receive the immunization according to the recommended schedule at their chronological age without the correction of the prematurity. So that means that they should do a standard. The chronological age of that means that if want to go back of their age or go further about their age. So consider the child birth weight, precise gestational age, and the presence of any medical condition. And this is the standard for every child. So this child, it doesn't have anything special at the moment and it's not extremely preterm. The birth weight seems also be fine and reasonable. The vaccination should be started as per standard. Okay, clear everyone, guys? Okay, great. This next question is, let me take my pen. So this is a pregnant lady at 18th week with persistent nausea, not resolving with metoclopramide, sudden onset of right eyelid fossa pain, likely diagnosis. I know there's a lot of information missing, and only two options. So first is red degeneration and second is acute appendicitis. So we have to decide between these two. What do you guys think about this one? Yes, most likely this looked to me acute appendicitis. Why? There are certain reasons because we just have two options. So I can just briefly discuss about those who are thinking if it's red degeneration. So there are two or three conclusive points which made me think it might be acute appendicitis. Though I agree that we have a lots of pieces and that information is lacking here. So this is the second trimester lady, persistent nausea. So persistent nausea means she might be having the nausea for quite a while now, and I'm not sure at the moment how long, but the recent onset is a right iliac fossa pain, likely diagnosis. So when they have a red degeneration of the pregnancy, yes, you are right, Dr. Wali, there is some history. So I agree we are lacking the history. Second thing, there is not as persistent nausea as they have documented for appendicitis. So appendicitis is known to have a persistent nausea which does not respond to the antiemetics first. And if you have think about right iliac fossa especially, they can give you more clue about acute appendicitis. So red degeneration might be the cause of nausea. It is a cause of the pain, but not right iliac fossa pain. So bits and pieces are missing, but most likely this question is going more towards acute appendicitis, not as to the red degenerations. History is missing. There's a persistent nausea which is not resolving. There is a right iliac fossa pain. So things like that give more information that it could be most likely acute appendicitis. But then again, if this question comes in exam, they should be having a clear indication and clear information about all the things happening. And especially they give you the history as well for the fibroid if this is a red degeneration. So this is, I think, for the appendicitis. And for the appendicitis, obviously with the initial primary survey and the secondary survey and things about CTG and after all the investigations, the patient, you have to think about either the patient is coming with the bleeding or non-bleeding. So a patient stands somewhere here. And then if the patient is having the peritonitic pain or the colicky pain. So if there's a peritonitic pain, you have to think about the conditions responsive to inflammation or infection, which is chorioamnionitis, abortion, septic in nature, endometritis, cystitis, appendicitis, and pancreatitis. So all these information, you have to alert the sepsis pathway, especially if your patient is having a fever with appendicitis, you have to start a septic pathway. Otherwise, you have to refer the patient for other investigations and to the specialist because the patient is coming with the persistent pain. If the patient includes the criteria, comes onto the criteria of sepsis, management is according to the septic pathway. So this was it about the red degeneration and appendicitis. Next question is, so this patient might be had the post MI, so post myocardial infarction last week, presented with sudden collapse. Next investigation, urgent echo or CT coronary artery or CT coronary angiogram. So again, missing information, but the only information is the sudden collapse. So this is post-MI. Many things happen post-MI. The whole anatomy of the heart changes, the vasculature changes. And also, if you have heard about the Dressler syndrome, it is the most common complication of the MI. So things can happen, but they have just two options. So CT angiogram and urgent echo. So if you just do the CT angiogram, it will not give you the information about anything else apart from the coronary arteries. But if you want to check with the echo, it will give you the information about everything apart from the coronary arteries. So I agree they have the MI, but if you urgent do the urgent echo, they can give you information about the valves, about the flow, about the ventricles, about everything else. They can give you the information. So urgent echo will be most feasible in that case because of the inflammation and the complication post-MI. So urgent echo post-MI could be anything from valvular dysfunction, ruptures, or things like that. Most likely, it's a rupture because of the valves. When there happens to be a Dressler syndrome, the patient is coming with a pericarditis pain. So I don't have much of the information here. It's just the collapse. So collapse means the patient has gone in a shock. Most likely, if the patient has gone in a shock, it's the information when the heart stops pumping, and because of the valvular rupture, it happens sometimes post-MI. Yes, valvular rupture can happen. If it would be the Dressler syndrome, pericarditis, you have a different sort of the history the patient is coming with. So echo most likely is the information or investigation that give you the clue about what has happened. I think I can show you something from this reference. So this is a post acute myocardial complications. It can be anything from these like cardiac failure, post-infarction ischemia. I'm not sure if it's clear. I can just maximize it a bit. Post-infarction ischemia, cardiac failure, ventricular rupture, ventricular septal rupture, acute regurgitation, thromboembolism, post-MI syndrome, which is Dressler's or pericarditis. So all of them have a different sign and symptoms and different investigations you can do about it. But echo is the one thing which can at least give you the insight of the information of the heart, what has happened, especially about the ischemia, ruptures, and thromboembolism as well. If there is some infarct there, any arrhythmias there, about the ejection fraction. Clear, everyone? Okay, great. Next question is, this is a 4-year-old boy with clear rhinorrhea, hit head on rock, briefly passed out, but fine since then. Tympanic membrane looks unusual. Concerned diagnosis. Fracture involving the floor of the cranial vault, meningitis, epidural hematoma. So this is a cranial floor fracture. I think we all agree on that. This is why they have a CSF rhinorrhea. And the tympanic membrane looks unusual. There could be some information they can give you about what sign is that. I'm sorry if somebody can recall the sign. One is a raccoon sign and one is what sign is that? Battle sign. That's right. Over the mastoid. Thank you. Yeah, so battle sign over the mastoid and the raccoon sign around the orbit. So these are two important signs which give you the information about the floor fracture, especially when there's the orbital floor fracture. And tympanic membrane looks unusual. I don't know what they mean. If the question was coming like that, or if the recaller has written like that. So usually, if there's if there is a blood involving there or blood leaking there, the tympanic membrane looks bulbous and it can give you some indication about if there is some blood inside the tympanic membrane, and obviously with the battle sign, they can confirm about it. But this is a fracture involving the floor of the cranial vault. Obviously, meningitis is not an option here. Epidural hematoma, if the patient is not having the clear rhinorrhea, then we can think about the epidural hematoma or other two options. But this is for sure the floor fracture. Hemotympanium, yes, right. Yeah, there could be the thing the otorrhea is indicating. Yeah, that's what I'm saying. It's unusual. Guys, can you please mute your microphones? Thank you. It's over the mastoid, Dr. Rehan. The battle sign is over the mastoid at the back of the ear. Okay, let's have a look on this one. So, fracture involving the floor of the cranial vault, periorbital ecchymosis, which is raccoon sign, CSF rhinorrhea, CSF otorrhea. This is what the tympanic membrane was looking unusual, or the hemotympanium. I think some doctor has mentioned that. Mastoid ecchymosis, which is battle sign. Then the paralysis of the nerves involving the face, which is fifth nerve paralysis. If the nerve is involving the ear, so it is a hearing loss from the eighth nerve. And these are the all complications which can happen with the orbital floor fracture or the cranial vault floor fracture. The management is obviously surgical. You will refer your patient to the respective surgical team. Quickly, next question. 80-year-old female, weight loss, anxiety, poor hygiene, bruises on left cheek, vague about incident. Most important differential: elderly abuse, new diagnosis of depression, new diagnosis of dementia. So most important differential, which you guys don't want to miss in that case, is the abuse. So as you remember, with the children, we are quite in Australia, if I talk especially about here, we are quite concerned about anything. So if the child is brought in by even their parents or even their relative and they have some bruises in their body or unexplained trauma or unexplained injury in their body, you have to inform the child protection services because you are concerned about their abuse. Same with the elderly, especially if you check about the age, she's 80, so you have to you are concerned about the abuse. She's coming with poor hygiene. She's coming with the bruising. She's vague about the accident. So maybe she having a dementia. But at the moment, the most important differential, which you don't want to miss, is the abuse. Okay. So if you have concluded that abuse and if you have ruled out the abuse, there is no point of having an abuse here. She's fine. Then you can think about anything else, especially if the patient is able to tell you anything. This patient is not able to tell you about anything because of vague incident. Now, abuse can happen within the homes, with the families, or they can happen in the nursing home as well. Usually, with the age like this, patients are coming from the nursing home to the hospitals or to your clinic. So you have to think about the abuse that can happen in their homes, if they are in their homes, or if they're not in their homes, in the nursing home, the abuse can happen there as well. And then you can just do your investigations according to that. So this is an elderly abuse. I can show you this quick reference from our CGP. So how you identify the abuse of the older people. So identifying the abuse, there are certain signs that can indicate that person is having the abuse, especially the elderly person. So unhappiness, isolation, unusual fear, worry, anxiety, appearing unusually unkept or particularly hungry or thirsty, unexplained injuries, bruises, or cuts. So all the information, I think all the three things or four things are here, fit into the criteria the patient we just discussed. There are also some characteristics of situations known as risk factors, which are common in the older people who experience abuse that should be considered when identifying when the abuse is occurring. And then understanding these factors can also provide the right support. So these could be the poor mental health, economical factors, disability, isolation, dependent on someone, substance abuse, things like that. And I think that's it for this. Some questions for me. Do we have to ask for consent to report the abuse from elderly like we in adults, or we have to do it mandatory? No, see, if the patient is, their elderlies are quite different, so they're adult, right? But if the patient is having a dementia, they are not able to give the information on their behalf, then you can report it. But if then the assessment comes in, the examinations come in, the MMSE comes in. So there are certain criterias where the adult or elderly have to fit in to be mentally viable to give you the information. Sorry, so if you do all the examinations and patients fits under the criteria of dementia, then you can report it. And you can look for their guardianship or the next of the kin in that case. If they're not able to inform you of their circumstances, then you can ask the collateral history from their nursing home or from their relatives. If nobody is there to give you information, then you have to look for the guardianship. Other question is consent of the elderly is required. This is, I think I've already explained. Consent is only required when the patient is non-competent. If she is competent, elderly is competent, and obviously she will tell you that what has happened. Because they are coming, usually I've seen the patients are coming with the dementia or even the delirium. They're not able to give you the information. In that case, either you want to wait for the delirium to be resolved while they're in hospital, or if their delirium is ongoing and they're not able to give you the information, you have to look for the collateral information from their nursing home, from their family, from their guardians, whoever is responsible. If she's not interested to report. Okay, that's interesting. So you have to find out why she is not interested to report. Is there a fear? Why? What is binding her or what is bounding her? Like she's not able to report. If there's a fear, if there is something else which is keeping her aside, so you have to look for those information as well. And as I said, collateral history is always helpful. So check their notes, check their nursing home history, ask their relatives, call them if you are able to reach them. If you're not able to reach them, then you can ask the nursing home to give the information about their relatives. If they're not able to give you the information, like if they are severely delirious and demented, they won't be able to share the information. So you can always track from the nursing home about their relatives. If it's out of fear, then obviously it's an abuse. Okay. Okay. Next question is a young lady, sore throat, fever, was given amoxicillin, presented few days later with diffuse rash over torso, has the persistent fever still and sore throat. What investigation to confirm the diagnosis? Throat swab, blood culture and sensitivity, specific IgE for the penicillin. Okay, so this question has two sides again. So first we are thinking, so we all know the rash developed because of the penicillin allergy. But we are still thinking that the patient has the condition which is resistant to penicillin. This is why she is persistent fever. So what you want to do in that case is you want to explore the condition first, or you want to explore the penicillin allergy first. There are two sides of this question. So, as a doctor, when the patient is coming back with the rash, once you give the antibiotic, so first of all, it's very rare here that the rash happens when the antibiotic is given. So, first of all, we have to check the allergy and give the information about the antibiotics and give them the antibiotics. But sometimes patients forget, sometimes it's a very new allergy that has developed. So, this could be the case. Now, the rash has developed. So, you want to check for the penicillin allergy, or you want to check for the resistant infection? What do you guys think about this one? Like what we have to do? So this question is a bit vague, right? It says what investigation to confirm the diagnosis. So I don't know what the recaller mean. Confirm the diagnosis for allergy or confirm the diagnosis for infection, the persistent infection. I think you have to discuss for the allergy first because it could be the underlying rheumatic disease. So rheumatic fever. So this is why we have to discuss. You have to see for the allergy first, IgE for the penicillin. Definitely, patient has something which the patient was not able to treat from the amoxicillin. But again, if we have more information, we can just discuss and argue more about this one. But at the moment, we have to see the allergy first. Why your patient has developed the rashes? So specifically for IgE penicillin, I think all the other options seem to be right as well, like throat swab because you want to check for the infection, culture and sensitivity because patient still has the fever. But this is something which you want to discuss if your patient is coming with the rash. You want to see why the patient has the rash. You have to check the specific allergy sensitivity for your patient. I can maybe show you one reference for penicillin allergy approach. Just stay with me, guys. I'm just looking for the information you want to discuss rather than just going through all of the reference. Okay, so this is all the information about the penicillin allergy. So, as the allergies can be life threatening, what you have to do is first, if the patient is coming with the allergy for the antibiotics which you have prescribed, first of all, you have to rule out the cause and you have to rule out the cause of the allergy. So, just take off the antibiotics, especially altogether, and you have to inform the patient and presume the immediate immune mediated reaction. A formal antibiotic allergy testing should be considered. While the management of patient with the penicillin allergy can be challenging, the cross reactivity initially is reported. So then you can just prescribe anything else. But the thing is, if your patient has developed the allergy from the certain antibiotics, and especially we're talking about the penicillin because it can be life threatening, you first have to find out the cause, rule out the penicillin allergy sensitivity, and you have to just change the antibiotic and just go for the treatment because this is why the patient has a resistance. Patient is having developed the resistance, is not able to cure with the amoxicillin. You have penicillin you have prescribed, and apart from that, they have developed the rashes. So rule out the allergy and then change the antibiotic for that. It can be EBV. See, it can be anything else because the patient has developed the sensitivity. The question gave us the clue that the information is there, that the condition was not treated, but they developed the rashes. So it could be EBV, infectious mononucleosis. So we have to think about that as well. But first of all, the thing is what investigation to confirm the diagnosis. Now, this was my question that what do you guys think what they're asking? They're asking about the allergy or they're asking about the second infection the patient has developed. So I think from that case that we have to rule out the allergy cause or confirm the diagnosis that your patient has developed the rash from that specific antibiotics, and then you can change the antibiotics always and just prescribe another antibiotics according to your sensitivity. It can come in some time, not very quickly the rashes come up. The patient goes home and come back after some 1 or 2 3 days, even 5 days, and come back with the allergic rashes. If they're talking about the infection, then if you're thinking it's EBV, you can do the throat swab. Okay, Dr. Zainab, infection if they're talking about, so they're talking about the infection which was not treated, and usually EBV we know the superimposed. So you can always do the throat swab and blood culture side by side. Okay. Next question is 74-year-old female with early mild dementia. Daughter wants to suspend her license due to driving concerns. True treatment about dementia and driving. So only these two statements we have to take a true statement. Dementia drivers at high risk of accidents or driving co-pilots reduces the risk in dementia. I can explain to you, Dr. Fazia, in a bit. So I'm just quickly just doing the winding up the session because we have just almost 10 minutes left. So already have two options only. So driving drivers, dementia drivers at a high risk of accidents. It is the right answer in that case. The second is driving co-pilot. Co-pilot is someone sitting with you and you are driving. So the person who is demented is driving and you are sitting next to them. This is co-pilot. And it says that reduces the risk of dementia, but the research says it doesn't reduce the risk of dementia. So if you're giving the steering to the person who is demented and you are sitting next to them, it doesn't reduces the risk of the accident and dementia. Okay, so the right answer is they are a high risk of accidents. And then we should think about if they are demented, clinically diagnosed dementia, then they should not drive. Quickly just check the reference from this guideline. I'm just taking you somewhere about the co-pilots thing. Okay, in this reference, there's the co-pilot as well, the information about the co-pilot, which you are basically not sure. Yes, safe. Yeah. So a driving co-pilot is not recognized safe practice for reducing the risk of dementia. Okay, the exact information we have our question. So co-pilot is someone who is sitting with a demented person is not a safe practice. So the only option we have was the number A, and we have already discussed that. So this was the option. Okay, clear, guys? Okay, sure. Quickly moving on to the next question. Sorry, I'm just trying to do as much as we can. Okay, so this 7-year-old boy, widespread bruising, leg abdominal pain, purpura, buttocks, legs, plus protein, urine dipstick, most likely diagnosis. I think everybody knows HSP or leukemia. That's right, HSP. And I believe we don't have to do it. If somebody wants to do it, we can just quickly do the reference. Do you want to discuss it with the reference doctors, or we should skip the reference and move on to the next one? Okay, majority, move on to the next. That's fine. Let's move on to the next. For those who want to do the reference is there. You can have a look, please, in your time. Next question would be also a quick one. So, 55-year-old male with left jaw pain, sharp shooting, words with chewing and hot and cold rings, no trauma or no swelling, likely diagnosis, trigeminal neuralgia, cluster headache, temporal arteritis. Yep, that's right. So this is trigeminal neuralgia because you have all the clinical information about shooting, sharp pain, worsening with chewing, or hot or cold drinks, especially, or they affect with the weather as well. No trauma history, no swelling history. So it's trigeminal neuralgia. And then again, we have a reference for trigeminal neuralgia. So I'm just skipping the reference as well, or you wanna do the reference? Skip it. Okay. Okay, that's fine. We'll skip the reference. I think you have done this topic before. This is why I don't want to go into the detail. I think I have done this